Okay, let's really get into this. Today, we're diving deep into a topic right at the heart of what we do as pediatric radiologists, the imaging features of child abuse.
Yeah.
And this isn't just reading scans, is it? It's about being a crucial gatekeeper in child protection.
Absolutely. And the sources, well, they really hit home why our role is so critical. Get this. Studies suggest that somewhere between 30 and 80%.
80. That's huge.
Yeah, 80% of confirmed physical child abuse cases are missed initially. It's staggering. It really underscores our responsibility, to pick up on subtle or atypical findings.
Right.
And it also explains why the terminology has shifted, hasn't it? Moving away from just shaken baby syndrome.
Towards things like abusive head trauma, AHT.
Exactly. Or inflicted traumatic brain injury, ITBI. It reflects a better understanding that it's not just shaking, there are other mechanisms involved.
So, okay, practically speaking, when we're looking at our screens, what does this mean? Let's start with skeletal injuries, second most common finding, right?
Mm-hmm.
This is where I think for us it gets really specific.
Spot on. You absolutely have to be looking for classic metaphyseal lesions, CMLs.
The corner fractures or bucket handle fractures.
That's them. They are incredibly specific, caused by these powerful shearing forces.
Like from shaking or twisting a limb violently?
Exactly. And the key thing, they're often subtle, often bilateral. You need really good quality radiographs to see them properly.
Okay. And then ribs. Posterior ribs.
Yes. Posterior rib fractures. Also highly specific, especially in the under 2 age group. We're talking an 80-90% positive predictive value for abuse there.
Wow. And that points to a squeezing force.
A direct squeezing, yeah. Compressing the chest.
And we should also keep an eye out for scapular, sternal, spinous process fractures, things you just don't typically see accidentally.
Right, those require significant force. But let's talk about the pitfalls, too, because it's not always clear-cut.
Good point. What about fractures that look suspicious but might not be abuse? Lower specificity ones?
That's a really important question. I mean, multiple fractures, especially if they're bilateral or look like they happen at different times, definitely raise suspicion.
Okay.
But spiral fractures, despite what many people think, they are not specific for abuse. They can happen accidentally.
Right, like a toddler falling awkwardly.
Exactly. And Lanier skull fracture is too common in accidents, but you need to look for the patterns.
Like multiple ones, or bilateral, or crossing suture line.
Precisely. That's when your suspicion should really increase.
Okay, shifting gears to the CNS. Subdural hemorrhage, SDH. Very common in AHT, especially in infants. But CT only shows so much, doesn't it? What else do we need?
Yeah, for really characterizing SDH, MRI is just far superior. Specific sequences are key. Susceptibility-weighted imaging, SWI, great for hemosiderin, helps with dating. And DWI, diffusion-weighted imaging, shows perfusion issues, low diffusivity, things highly linked to AHT, and unfortunately long-term damage.
And don't forget the spine.
Never forget the spine. Always think about imaging the whole spine, particularly lumbar, because SDH can track down there.
Okay, and then there are visceral injuries. Critically important, second leading cause of death from abuse, sadly.
Yeah, it's grim. The liver is the most common abdominal organ injured. But what's really alarming, and the sources highlight this, is how rarely we actually see it radiologically documented in living kids under 1.
Why is that? Delayed presentation?
Often delayed presentation, yeah. And also, any pancreatic injury in infants or preschoolers, that should be a massive red flag.
So maintain a really high index of suspicion with vague abdominal symptoms, especially if the story doesn't quite add up.
You have to. That inconsistency, the mismatch between the story and the injury, that is paramount. Remember, those really specific injuries like CMLs, they might have zero outward signs.
Making the history or lack of a consistent one even more critical.
Exactly. It puts more weight on our imaging interpretation.
So how do we reliably tell abuse apart from mimics, like osteogenesis imperfecta, OI, or even just normal variants that can look weird?
Yeah, this is where careful analysis is vital. With OI, you're looking for generalized demineralization, maybe bowed long bones, metadiaphyseal fractures different from the metaphyseal CMLs in abuse.
And rib fractures and OLAs.
Typically rare, usually single, not the multiple bilateral pattern you might see in abuse. And a really crucial point about CPR, it very rarely causes rib fractures, and it has never been reported to cause posterior rib fractures.
Good to know. So differentiating from normal variants too.
Yes, things like, normally pointed metaphyseal borders or metaphyseal collars. You have to know what normal looks like to spot the abnormal.
Okay, last big piece, the report. Given the huge medico-legal weight, how do we make sure our reports are absolutely solid?
Right, the 5 C's are essential: complete, correct, conclusive, cogent, and clean. We need to be cautious with dating injuries, though. Skull fractures, metaphyseal lesions, it's not an exact science.
So instead of pinning down exact dates,
Focus on describing different stages of healing. That suggests multiple events over time. And avoid potentially misleading terms like acute on chronic for mixed attenuation subdural hemorrhages.
makes sense. And follow-up skeletal surveys.
Vital. Standardized 10 to 14-day follow-ups. They can reveal evolving healing changes, which is often critical evidence.
Wow. This whole area really underscores the huge responsibility we have. It's a challenging field, often dealing with alternative explanations. Requires us to be so scientifically rigorous and ethically grounded.
Absolutely. And if you think about the bigger picture, our careful work, sticking to protocols, reporting precisely, it's not just diagnosis, it's a protective function.
For the most vulnerable kids.
Exactly. Which just highlights why ongoing learning and working closely with other disciplines is so important.